As regular, we meet on the first and the third Fridays of a month at 14:30 hours Indian time. And in today's webinar, we have Dr. Parimalam Kumar, the professor and head of the Department of Dermatology, Madras Medical College, to talk to us. Friends, most of you are aware that the initial editions of the webinar series were all on COVID-19. In fact, the university embarked on a kind of a webinar series primarily because of the pandemic situation wherein we could not have our physical meetings. And as all of us are anxious to bid farewell to COVID, and in a way trying to prepare ourselves to bid COVID to in the next few weeks or few months, we again have a topic on COVID-19. And Dr. Parimalam Kumar would be talking to us on the cutaneous manifestations of COVID-19. I suppose this is the correct time that we think of this topic. In the acute phases, probably not many people were bothered about the cutaneous manifestations. The initial waves, especially the first and the second waves, it was more of saving people and not looking at their skins. It's fine if the skin was not all right, but then the other areas, the life-saving areas, required more concentration. I'm not here to say skin is not a life-saving area, but then the other systems demanded more concentration. But probably in about 2 years' time, we've started seeing more of cutaneous manifestations, and it's with this topical importance that Dr. Parimalam Kumar would be talking to us on this topic. And joining Dr. Parimalam in the discussion as panelists will be Dr. Dhanalakshmi, the former professor of dermatology at Madras Medical College and currently the professor and head at Panimalar Medical College Hospital and Research Institute. And with her is Dr. Dincy Peter, the professor from the Department of Dermatology, Venereology and Leprosy at Christian Medical College, Vellore. To introduce Dr. Parimalam Kumar formally to this platform, Dr. Parimalam Kumar did her undergraduate studies from the Madras Medical College and subsequently her post-graduation in dermatology, both at the diploma level and the master's level from the same institution. She has 27 years of teaching experience to her credit and has co-authored books and has also contributed chapters in dermatology books. She is currently the Vice President of the Indian Society of Teledermatology and the President of the Indian Association of Dermatologists, Venereologists and Leprologists. With a very active membership in the Indian Association of Dermatologists, Venereologists and Leprologists, and in the Telemedicine Society of India, she is also an associate life member in the Indian Academy of Pediatrics. She is a member of the Dowling Club, which is a branch of the British Association of Dermatologists and a member of the International Society for Pediatric Dermatology. Dr. Parimalam Kumar is an active member of the profession, having served in various capacities while organizing national and state level conferences in dermatology, and also is a person with a bent of mind to respect the seniors. I know with my personal experience, her penchant to respect the seniors of the profession and her contribution in that area. I deem it a great privilege to welcome Dr. Parimalam Kumar this afternoon, and also welcome Dr. Dhanalakshmi and Dr. Dincy Peter, and all those of you who have joined the webinar. Welcome, Dr. Parimalam Kumar, and the floor is yours. Please go on. Thank you.
Thank you very much, ma'am. Am I audible, ma'am?
Yes, you are.
Ma'am, I must first express my heartfelt thanks to you for choosing me to share this platform and for those nice words, ma'am. Thank you very much, ma'am. Today, we are going to see the cutaneous manifestations of COVID-19 infection. COVID-19 is an ongoing global pandemic caused by the severe acute respiratory syndrome coronavirus 2, the SARS-CoV-2, which was isolated for the first time in Wuhan in December 2019. Common symptoms include fever, cough, fatigue, dyspnea, and hyposmia. Among extrapulmonary signs associated with COVID-19, dermatological manifestations have been increasingly reported in the recent past. The polymorphic nature of this COVID-19 associated cutaneous manifestations could be better studied only if we are able to classify them. There is widespread consensus on considering vascular damage as a central player in the cascade of coagulation abnormalities, eventually leading to thromboembolic complications in the severely ill COVID-19 patients. Coming to the dermatological aspects, COVID-19 has been occasionally linked to histologically confirmed cutaneous vasculitis and a Kawasaki-like vasculitis, with these entities generally having minimal or no lung involvement and having a relatively good prognosis. Unlike these vasculitis types, patients with severe COVID-19 pneumonia can develop cutaneous vasculitis-like lesions and systemic arterial and venous thromboemboli. Proposed mechanisms may include immune dysregulation, including an antiphospholipid syndrome-like state, complement activation, viral dissemination, and direct systemic endothelial infection. And not to say about viral RNAnemia. With this brief dry theory, let's move on to the actual literature. See, now we know that we are going to the third wave. I'm not able to move my slide. Yes, now we are going to the third wave, and hopefully we do not see the fourth wave, and this pandemic will come to an end, maybe settle as an endemic. Why, as dermatologists, we should know about this COVID-19 and its manifestations is because there are certain manifestations which are peculiar to COVID-19, and there is some skin change because all of us have changed our lifestyle due to COVID-19, and adverse reactions to those drugs which are used to treat COVID-19, and the effect of therapy, what we are giving for our skin disease patients. And finally, now we all are in the process of getting vaccinated. So the vaccine-induced skin manifestations. My flow of this talk will be, we shall briefly review the literature. I shall share my own experience and a few take-home points. So when we want to classify the skin manifestations of COVID-19, different authors have made different classifications. This is one type of classification where the three distinct patterns include the vasculopathic lesions, the COVID toes, and the vesiculobullous lesions, which simulate varicella. The three Less distinctive lesions indicate dermatitis-like, there is eczema-like picture, macular-papular rash, and the urticarial lesions. We all know that the first three occur in the severely ill patients, and the second three probably in the moderately ill and also in the mildly infected patients. So this is yet another classification where they're concentrating exclusively on the skin manifestation. The urticarial rash, confluent erythematous maculopapular or morbilliform rash, papulovesicular exanthem, chilblain-like acral pattern, livido reticularis, and purpuric pattern. So let us take one by one and what the literature tells us so that we will understand the pathophysiology better, whether we have to diagnose the disease, treat the disease, or take it for prognostic significance. The acroischemia can present just like an ischemia, or it can manifest as a cyanotic digit. It may go on to the extent of forming a gangrene. In some studies, 4 out of 30 patients who had DIC presented with COVID dose. Fortunately, we in India, at least in the South India, do not come across this probably because of our weather, irrespective of the medications. So this perniosis, pseudo-chilblain, and COVID dose, they can be secondary to the systemic consequences caused by COVID, or it can be due to the type 1 interferon mediated complement activation. And this complement activation subsequently results in microangiopathy. And all of us know for sure that it is not one system, it is every system, because all the systems are supplied by blood through vasculature. So wherever there is microangiopathy, the system gets affected. Erythematous to violaceous papules can present over the acral surfaces. I shall let you know why these are all important, because there may be very little difference between a cyanotic hue, violaceous papule, and a pallor. But unless we know these fine details while making rounds, we might miss out on some of these manifestations. Pain, pruritus, paresthesia, blistering, crusting, ulceration, all of them should not be ignored when a patient complains, especially in an inpatient setup. Libido-like changes are very, very rare in our setup, but they are commonly presented from the Western literature. All said and done, most of these lesions are self-resolving. Recurrence may be possible if there is repeated exposure to cold. When you go to vasculopathy, again, the libido is secondary to the coagulopathic consequences, whether it is due to COVID or due to the treatment. There is always a complement activation. We know that there is a storm, cytokine storm. In addition, there is complement activation. There is endothelial dysfunction. Sometimes the endothelium undergoes dysfunction, or there is active inflammation leading to endotheliitis. Whether it is due to the thrombosis or the viral inclusion or due to widespread systemic coagulopathy, we are not able to confirm, because this is the first time we are seeing all these manifestations. And as Madam rightly pointed out, we did not have enough time to do research on all this. I mean, extensive research. The end result of vascular occlusion, we know, is gangrene. Superficial microthrombi may lead on to arterial thrombi and also can go into the deep dermis and manifest as covetose. When libido is manifested, we see net-like pattern and not a blotchy erythema. And buttock is the predominant site, maybe because of dependency. But in our setup, we do not see libido. Maybe one, we are dark colored. Number two, the vascular component of libido maybe is due to other manifestations, not exclusively due to COVID. The vascular eruptions, are they due to the immune response against the viral antigen? If it is so, it has to be diffuse. If it is due to pressure effect and other traumatic effects, then it can be localized. So when you come to morbilliform eruptions and macular erythema, again, these can be an immune response to the viral antigen. Not to forget the drug eruptions. A patient with fever without knowing that it is due to COVID might have taken some drug. That can lead to drug eruption, and subsequently the patient may turn out to be positive. We do not know whether that maculopapular rash is due to the drug or due to the viral infection, because it typically starts from 4 to 14 days after starting with the new medication. By the time our RT-PCR comes positive, it is already 4 or 5 days over. So we are in a dilemma whether it is drug-induced or COVID-induced. And they have even reported such maculopapular rash to azithromycin, lopinavir, and also to HCQS, because in the earlier days, HCQS was given as even a prophylactic dose for COVID. And as far as possible, it is advisable not to give HCQS. Morbilliform lesions predominantly occur in the trunk and then spread to the extremities, which is invariably symmetrical. But here, one thing which can easily be differentiated, one point that helps to easily differentiate it from the drug reaction may be the intense itching of the palms and soles may not be present if it is due to COVID-induced morbilliform rash. If it is COVID-induced morbilliform rash, it may be pruritic, it may be asymptomatic, but it involves almost 90% of the body surface area. If there is a violaceous or purpuric component, we have to be extra careful and understand that there is a bleed into the rash. So if the patient is not already on heparin, we know that this patient is going to have a very tough time. He may slip from mild to moderate to severe form of COVID. When you can differentiate from dress and HM, those resolve with darkening. So why we should be very particular about these lesions is when we face teleconsultation, some patients will come to us, I'm having fever, I'm having rash, I have not taken any tablet. These are the situations when we have to be extra careful, because as per the ICMR guidelines, we are not supposed to do RT-PCR unless we have COVID symptoms like fever and cough and not skin rash. So these are the situations where a dermatologist has to be extremely careful and watch the patient and monitor the temperature, respiratory rate, and the oxygen saturation. So these are the important aspects whenever we come across maculopapular rash in a patient with fever. Sometimes even without fever, without a drug intake, there can be a maculopapular rash. All that we can do is only follow up the patient and do the RT-PCR only when the patient becomes symptomatic. Urticaria is a very, very common manifestation in almost all dermatologists will see at least one urticaria every day. Urticaria in COVID may be an immune response directly to the viral antigen, or again due to the drug haptens. This is IgE mediated immediate type hypersensitivity reaction, and we know that. And sometimes even our hydroxychloroquine can manifest, drug treatment with hydroxychloroquine can result in urticaria. In COVID, wheels are sharply demarcated and pruritic, which last for less than 24 hours. Once again, here the trunk is more commonly involved. Why I'm marking this immunosuppressive agents? When we as dermatologists are facing with our own patients, when to give immunosuppressive agents, when to stop them. If a patient is asymptomatic, I mean for COVID, if the patient is asymptomatic and if he is COVID-19 negative, we need not stop the immunosuppressive drug that we are giving. For example, if the patient is on methotrexate, a psoriasis patient is on methotrexate, is asymptomatic, is COVID-19, please continue with methotrexate. These symptomatic patients having fever, cough, and they are COVID-19 negative by RT-PCR, we must avoid high-dose steroids whenever possible, depending on the severity of the skin disease. if there is a high risk of COVID-19 related complication, we have to consider the importance of continuing or stopping the immunosuppressive drug. We have to bear in mind the condition of the patient, not condition of the disease, actually. The condition of the patient, which includes the comorbs. Supposing we cannot take a stop in psoriasis, stop in pemphigus, stop in connective tissue disease. Whatever be the disease, we have to take into consideration the need for monitoring and the comorbidities the patient has and the control of those comorbidities. If the patient is symptomatic and he's also COVID-19 positive by RT-PCR, please stop the immunosuppressive agents. And there are certain exemptions for this, about which we'll see at a later, in a few slides from now. We are giving cyclosporine for our psoriasis patients. If the patient is on cyclosporine, according to literature, there is no need to stop cyclosporine if the patient becomes positive, because they say cyclosporine patients on cyclosporine need not develop severe COVID infection. Similarly, there is also a literature report stating that those patients who are having atopic dermatitis who are treated with dupilumab had less severe manifestations of COVID when compared to those patients who have been treated with other drugs like your steroids and phototherapy. So coming to the use of biologics in psoriasis during COVID pandemic. Of late, we have started using biologics for many reasons, including failure of the other drugs or inability to use the other drugs due to associated comorbidity. And third, which has to be insisted here, is availability of the drug and affordability of the patient. Supposing a patient is rich enough, he wants to use biologics. Nowadays, the demand using biologics. So patients on psoriasis who are treated with biologic agents appear to be having an increased risk for developing COVID-19, except secukinumab. Secukinumab is supposed to be preventive, again, not preventive. It is not going to worsen the viral disease. It may worsen the fungal disease. So the biologics, what is the problem or advantage with biologics is that they have longer half-life. So you cannot just like that stop the treatment. For example, if you give a drug and if the effect is going to be over in 6 hours or 8 hours time, we are fine in using those drugs in COVID pandemic. But if the drug has a very long half-life, the effect of the drug is going to be within the patient and it is going to have either good or bad effect. TNF inhibitors, overall, they worsen the URI upper respiratory infection up to 7%. However, etanercept is supposed to be better than all the other TNF alpha inhibitors. Similarly, the IL-17 blocker secukinumab increases URI slightly, but it has not caused a dangerously ill respiratory infection. Ustekinumab, which is an IL-23 inhibitor, can cause a small increase in the overall infection and it causes increased susceptibility to viral infection. Among the psoriasis patients, what we can do is, this is a very, very simple table which will just tell us TNF alpha inhibitors except etanercept can be used during pandemic, but they can produce bacterial infection and fungal infection. Therefore, it is better not to use them except etanercept. Similarly, IL-6 inhibitors, they can cause increased incidence of bacterial infection. Whereas IL-23 and IL-4 and 13, drugs against IL-23, IL-4 and 13, they do not increase the incidence of viral, bacterial, and fungal infections. Whereas IL-17, which is secukinumab, causes increased incidence of fungal infection. And of late, we are talking about JAK inhibitors, that is the tofacitinib. Tofacitinib is frequently used because it is easily available as a oral drug. Again, here it is not advisable to use tofacitinib when we are suspecting viral or bacterial infection. So these are different patterns and percentages of cutaneous rash observed in various parts of the world. For example, in China, the cutaneous manifestation was 0.2%. Whereas in Italy, if you take it is 20.4%. And if you take Spain, the cohort was 375 only, and 47% had cutaneous manifestation. And we undertook a study in Stanley Medical College. It is huge number with 5,460 patients. Believe me, we did it ourselves. How we were able to do is that was a time when none of the hospitals had bed for patients. All the hospitals were full. And we used to have so many patients every day, and all the floors, all the OP were attended by the dermatology. 6 dermatology PGs were posted, and they saw all patients over a period of 1 week. And I too saw all of them. And earlier, I had seen the patients in the care centers. So we did a study and we grouped them as symptomatic patients who were treated in the hospital, asymptomatic patients who had comorbidity with who were treated in the corona treatment centers, and asymptomatic patients without comorbidity who were taken care of in the corona care centers, and those asymptomatic patients who were allowed to go on home quarantine. And the last is patients who come to the skin OP later diagnosed to be COVID positive. And finally, due to drugs. So we categorized them and we just saw how the manifestations was different in different places, I mean, different groups. And we also included the cutaneous findings in healthcare providers. So based on our findings, we just arrived at a practically applicable flowchart, like the COVID-related skin manifestations in the hospital. We are not talking about those corona care center, because in all those places, patients came to us with exacerbation of their existing skin disease. But here, they had new lesions. So COVID-related skin manifestations in the COVID care hospitals, that means inpatients, IPs. We divided them into vascular lesions, non-vascular lesions. Under the vascular lesions, it can be either a COVID-2 vasculitic lesion, simple petechiae, purpura, or ecchymosis, or livedoid pattern. Under the non-vascular pathology, we just broadly classified them into non-emergencies and emergencies. Under non-emergency, we had maculopapular rash, eczema-like rash, urticarial rash, vesicular rash, figurate erythemas, and under emergency, we had adverse drug reaction and erythroderma. So this is the first experience for me rather, because I had a call from the medical department, come and see, there is one patient with COVID and he has got some skin lesion. The lines that you're seeing is the shadow of the window. We were not able to go inside the ward. We didn't know the protocol. Nobody knew what it was all about. So from outside we saw, and these were the 2 vesicles. So what I thought, if you see the second picture on the right side, you're able to see the umbilication. So I thought this is a case of varicella. Not bad. We have picked them up at a very, very early stage within 24 hours. So we gave the patient acyclovir from the hospital. And of course, the patient improved well. So we thought it was a varicella, which we controlled. So you see the difference. Here he had, on the right side, there is central umbilication, though there was not much of erythema around, which can be justified because the patient is dark. And another patient again developed group lesion, but this time we knew after reading the literature that it is not varicella. So the COVID patients who have vesicular eruption are not varicella infection. So this histology we did not know. This is from the literature. So the histology may show intraepidermal vesicle. Some authors say suprabasal vesicle with acantholysis, keratinocyte necrosis, and complete epidermal detachment. So these are some of the pictures, maculopapular rash. And you can see this is, we don't know whether it is drug induced or viral induced. So you just see the palms and soles. If the palms and soles are relatively spared, we know it is viral induced. And this ecchymosis is a very, very common feature in those patients in the ICU, maybe because they are on heparin. This is an interesting case. During follow-up, some of the patients developed these type of purpuric lesions, not necessarily when they are inside the hospital, even at the follow-up state. And these are all vasculitic lesions. And this is COVID digit. We won't call it COVID though, it is a COVID digit. So this COVID digit histology, definitely we did not do for the sake of other listeners. It can present as lymphocytic exocytosis, macular degeneration of the basal layer, something like a vasculopathy with papillary dermal edema, and endothelial cells show swelling. But distinctly, what we've been seeing is there is no fibrinoid degeneration. Nobody has mentioned fibrinoid degeneration of any of these pathology. So now another important aspect is when you see a patient with purpura and ecchymosis, you think that it is heparin-induced thrombocytopenia with low platelet, of course. You think it is heparin-induced thrombocytopenia. But when the patient is not on heparin, what are we going to consider this as? It is either immune thrombocytopenia or disseminated intravascular coagulation. So a very simple test is just get a peripheral smear done. If it shows fragmented RBC, you know you are dealing with either immune thrombocytopenia or DIC. And go ahead with PTINR and fibrinogen level. If it is normal, again, you know, you're dealing with a case of immune thrombocytopenia. But in my experience, patients with immune thrombocytopenia and patients with DIC, they bleed inside. Because though I said this for approach, 4 or 5 patients I have come across, they do not bleed into the skin, they bleed inside the organs. It's very, very pathetic because we find it out at a very late stage. If there is a clue on the skin, we could have started the treatment early. So this is urticaria, which is very sharply marked, and it starts in the abdomen and trunk and later goes to the extremities. This is erythroderma and pustular eruption. This is one important observation we made. Those ulcers which are present when they develop COVID, when they are treated for COVID, these are all inpatient pictures. The bleeding is little more from the ulcer area. It may be due to the heparin. Even in those patients who are not on heparin, the bleeding was more. So this is another pressure ulcer in the leg as well as in the lower lip on, observed in patients who are treated as moderately severe COVID who are not on heparin. Again, non-healing ulcer, they just become more erythematous and they start bleeding more. These are all at the Corona Care Center. They present with insect with hypersensitivity like reaction, exaggeration of acne vulgaris, more pustular lesions. This is in short our observation. We had 5,460 patients. Under category A, we had 524, that is within the hospital. Category B, Corona Care Treatment Center. Category C, Corona Care Center. Category D is home quarantine, and category E is those patients incidentally who were found to be positive or who became positive. And if you see, the vasculitic lesions are more in category B and category A. Similarly, acne, cirrhosis, all these are exaggerated in home quarantine or patients who are regular visitors of the hospital. So these are some of the manifestations which all of us have been seeing. This is a healthcare provider. Look at the margination, look at the demarcation of the glove area. So this is contact dermatitis, and this pigmentation takes longer to disappear. And this is pseudomonas infection, obviously because of repeated hand wash. And here this is keratolysis punctata because of repeated hand wash and moist hand. It can be as severe as this. And this is the worst scenario which you can imagine. This is a person who was taking care of her husband who is COVID positive. And she used to use sanitizer so frequently. And once it so happened that it spilled on her dress and arms. And she went to light the stove. She just got fired. So this was a not scald, it is a burns for no fault of hers. And healthcare providers, the pressure effect due to the boot and all that. And also when you wear mask very regularly, these are some of the manifestations: contact dermatitis, acne, pityriasis versicolor, tinea faciae, and also what I have shown like keratolysis punctata, hand eczema, paronychia. All these are due to constant washing. Feet eczema and intertrigo is because of very, very constant wearing of those boots by the sanitary workers. Flame burns, the worst of all which I have seen so far. It's such an extensive burns. So this is herpes simplex. You can see the extent of tinea faciae. Earlier, we were not seeing so many tinea faciae. Of late, we've started seeing so many tinea faciae, maybe because of the use of mask. And once again, tinea faciae as well as exaggeration of acne. And this boy, I'm not able to take the picture of his brother, though both of them share the mask. Only one. The one boy only comes with a mask. He goes outside, gives his mask to the other younger brother. He will wear that and come inside to show himself. Both of them had molluscum contagiosum in the mask area. And for those postgraduates, you please concentrate on the submental lymph node. That is a clue. So this is cutaneous manifestation of COVID-19 we have come across. Lifestyle alteration we have seen. And medication we know how to differentiate. And COVID therapy can lead to some diseases. But what we are going to see is COVID-19 symptoms are attenuated in moderate to severe atopic dermatitis patients treated with dupilumab. What does it mean? It means if the patient is on dupilumab, please do not stop. Let him continue on dupilumab so that even if he gets COVID positive, he will have only mild to moderate disease. And course of COVID in psoriasis. Secukinumab can be safely continued in patients exposed to COVID-19 with a favorable course and rapid recovery, even in the more critical patient. That's what the literature says. And it is better not to use other immunosuppressants or a very high dose steroid. Similarly, in pemphigus, it is better that we do not use rituximab. It is enough if you treat them with steroids. We have an example for that. This is a patient with pemphigus, and you can see for yourself the patient is all right. We did not give her rituximab. She was just managed with injection decadron, but we did not give her pulse either. So these are the observation in short. The commonest cutaneous manifestations we came across was maculopapular rash. We have to differentiate from the drug reaction. Ecchymosis and purpura are more common in very severe COVID patients who are in the hospital taking heparin. Vasculitic lesions heal without scarring. We have to understand that because it is not like the vasculitic pathology of others. Vesicular eruption can mimic chickenpox, and we have by experience learned that this is not chickenpox and it is only the vesicular eruption of COVID-19 and it does not require acyclovir. Urticaria, what we have come across is the surrounding erythema is more than the wheal. Maybe it is the central pallor. Is it because of the vasoconstriction? We do not know. And after having seen so many diseases and patients getting positive for COVID, these are our observations as to what happens to some of the diseases when they get COVID positive. The ulcers worsen and bleeds more easily. Seborrheic dermatitis, acne, cirrhosis, insect bite hypersensitivity, all of them worsen, not all of them, most of them worsen when they develop COVID positivity. Psoriasis worsens in some, but in some it does not change the course. For some people, since we stop the high-dose methotrexate and high-dose cyclosporin and bring it down, maybe that is the reason why it worsens. And autoimmune bullous disease, there is not much of a change. Even just 2 days back, we got one patient transferred back to our ward who was COVID positive. We just stopped the daily dose of steroid, and now he's fine. Bullous pemphigoid in some patients after they acquire COVID infection becomes psoriasiform. Even otherwise, we have observed this kind of a manifestation, but distinctly we have seen this after COVID-19 infection. So overall, the disease outcome in patients after acquiring COVID infection, be it psoriasis vulgaris, pustular psoriasis, erythrodermic psoriasis, pemphigus vulgaris, bullous pemphigoid, mycetoma, stasis ulcer, tropic ulcer, in Hansen's patient who was released from control, all eczemas, all these are our inpatients, both in Stanley and MMC, who have acquired the infection, transferred to COVID ward, brought back to our ward. It did not have much of a change. Whereas drug reaction patient who was being treated in our ward when he developed COVID, COVID was severe and he had to go through dialysis, and one of our drug reaction patients we lost. We have to actually go through literature, pathogenesis, and analyze what could be the cause. So healthcare providers, all these are some of the extra gadgets which actually lead to clinical manifestations of their diseases. And now coming on to the vaccines, vaccine can cause cutaneous manifestation either as an immediate hypersensitivity reaction or as a delayed hypersensitivity reaction or just like a molecular mimicry or due to an autoimmune mechanism. The cutaneous reaction to COVID-19 vaccine at the dermatology primary care. This is the latest. Out of the 200 vaccinated patients admitted in dermatology primary care, only one patient required hospitalization. This is really encouraging because that one patient can be hospitalized even without vaccination. So what we really want to convey is vaccination is not going to cause a statistically significant troublesome cutaneous manifestation. So COVID arm, as I was browsing, I just saw this, and this name is really nice, COVID arm. Every one of us, I'm sure, would have had this. It's a delayed hypersensitivity skin reaction, not necessarily obvious for you to have erythemas, pain, or swelling. All of us developed some sort of a swelling over the site of injection. There could have been at least a slight warmth over the skin, and mild and subtle erythema would have been there. This symptom shows up several days to 1 week or more after that, and it automatically subsides. So this is another, I have seen at least 4 or 5 patients who developed herpes zoster post-COVID vaccination. This can be easily attributable, not that COVID vaccine is precipitating, even otherwise, maybe because of any other viral infection, when their immunity goes down their main critical level, they might develop herpes zoster. So to conclude, these are all the manifestations percentage-wise in COVID, whereas skin manifestation is less than 2%, except for some studies, more or less, it is less than 2%. And what is more important is there is not one skin manifestation which you can point out and say, okay, if you have the skin manifestation, go get an RT-PCR done. It is a cutaneous manifestation for COVID. No, there is no pathognomonic skin finding to diagnose COVID-19 infection. It only helps to suspect the disease and assess the severity, of course, to monitor the prognosis. Skin manifestations alone do not warrant swab testing, and immunosuppressive drugs in COVID negative persons can be safely used, and COVID vaccines are safe. So this was the latest, very latest news. COVID will always be an epidemic virus, not an endemic one, scientists want. Let it be an epidemic virus or an endemic virus. And let us stop waiting for a better word. Let's start working on it together, and 100% we will be able to achieve more than what we are now seeing, and we will be able to contain this disease. I once again profusely thank our VC ma'am for giving me this wonderful opportunity to share a few of our thoughts and our experience in this platform. Thanks a lot, madam.
Video on button.
Yes, madam. Thank you very much, ma'am. The Dr. Dhanalakshmi, ma'am.
Yes.
Yes, madam. Please add your views and ideas and what is your experience in seeing skin manifestations in COVID-19 patients, ma'am.
Actually, as Dr. Parimalam Kumar told, there is no specific skin manifestations in the COVID we have seen in our experience. But I happened to see one or two patients, they come for herpes zoster. Next week, they call me, they had a COVID. So like that, it is continuously 3. In another incidents, there is one company, this actually related to with this drug company. It is one by one, they all had herpes zoster. I was wondering how herpes zoster is infected from one to other like that. But after some time, they told most of them, like 3-4 people came for herpes zoster. So almost 10 to 15 people had COVID in their company, it seems. I request Dr. Parimalam, you have any literatures like this?
As per the literature, post-COVID vaccination, herpes zoster is a manifestation, not pre-COVID.
Yeah, see,
In the
this
literature,
thing,
they say,
history was like this. There is no vaccine. That time, vaccine was not available during the first episode. It was.
and that's what maybe following any viral or bacterial infection, the host immunity comes down below the critical level. When the body is not able to contain the virus any longer, as per the Hope's hypothesis, the zoster surfaces. Maybe this is the infection which has caused the lowering of immunity in the host, and therefore the herpes zoster manifested.
Maybe that is the one reason. Even before they developed the COVID, they had some. There is some evidence that they have a viral resistance lowering. That's why they contained virus of herpes zoster. They manifested. It was the one incidence I met it. That's the thing. Another thing, in post-COVID patients, is there any increased chance of post-herpetic neuralgia? One of the patient,
So far.
one of the patient, they
that can be
complain, yeah, very severe post-herpetic neuralgia. Maybe that is the inherently she is prone for the post-herpetic neuralgia. Might be. Okay.
maybe a retrospective analysis will
Yes.
definitely throw more light.
Yes.
Because here and there we are seeing 1 or 2 cases. If you're able to collect all the data and compare it with those who have not had COVID, maybe
Yes.
that will really give us the idea.
Any protocol for the minimum interval to restart the methotrexate or cyclosporin
15
in
days.
COVID individual
We say
patients?
15
Yes, for
days before and after, it is better not to have immunosuppressive drug. 15 days before vaccination and 15 days after vaccination.
okay. After
Start
the
2 weeks
COVID,
before.
COVID disease.
COVID infection, you're talking.
Yes,
Again 15
yes.
days.
Okay.
Again 15 days we'll have to wait. Because I have had quite a few of my psoriasis patients when they don't know how to stop before the disease.
Yes,
So
yes.
once they tested positive, I tell them to stop everything. And after 15 days, that is RT-PCR gets negative in 1 week's time. And after that, 15 days after RT-PCR negativity, I ask them to start.
Regarding
And
the biologics.
surprisingly,
Yeah. Yes.
Despite stopping the methotrexate, there wasn't a sudden exacerbation of any of those diseases. Mild worsening was there, but not a sudden exacerbation.
Okay. Regarding the biologics, you already told secukinumab is relatively safe. It is not lowering the resistance to the virus. What about the other things?
No, it is better to use. We should not be starting on any new biologicals. Maybe now we can start. During the second COVID pandemic, we did not do that. Now we can start on biologicals. But only problem here is if the patient is going to develop COVID, the biological effect is going to be within him. So now we are at liberty to start on any biological, provided the patient needs it.
But initially we thought the COVID will go by 1 year, 9 months, 6 months, but it's going on for 3 years. For 3 years, we have to almost third year we
No,
are
now
on.
we have started giving biologicals, no?
Yes.
Keeping our fingers crossed. And another
Yes.
advantage is all of them are vaccinated now. Most of them are
Yes.
vaccinated.
Yes.
So that gives us a little confidence that the disease is not going to be severe for them.
Yes. At least a moral support it gives. Is there any incidence of increased herpes simplex after the vaccination?
Herpes simplex after vaccination. No, I have not come across.
But usually
Herpes
patients.
zoster I have come across, not herpes simplex.
Okay. But actually, the patient's tendency is to attribute to everything happen, whatever happens, it is to the vaccine. Whatever fever, whatever headache, whatever skin rash. But I have seen quite number of pityriasis rosea like reactions after the vaccination. Is there anything in your practice?
Yes. When cutaneous maculopapular rash we have come across. Similarly, urticaria also post-vaccine we have come across.
Yes, but a typical pityriasis rosea like with the herald patch. Yes, with the herald patch and all the regular course, like typical pityriasis rosea reactions. Anything increased incidence?
No, I think we'll have to again go through, take a retrospective analysis and see like what is the incidence in general public and what is the incidence post-vaccination. Is there
Post-vaccination.
any time duration between the vaccine and the drug rush?
Okay. I request Madam Vinci Peter, Madam.
Thank you, ma'am. Thank you for this invitation here to be the panelist. And I congratulate Dr. Parimalam ma'am for giving such a extensive, lucid presentation. Actually, she classified the available literature about how the COVID-19, the cutaneous manifestations of COVID-19. And also, I really thank ma'am for sharing her pictures of her experience actually in COVID-19 and about how, as dermatologists, we deal with patients who present or who are susceptible to COVID. So it was a wonderful presentation, ma'am. And I like to share that, as you have mentioned, in our CMC, we haven't seen so much of vesicular eruption at all. Actually, what we saw was like few maculopapular eruption. One of our patients, whom we thought was dengue, like characteristic sparing of rash with areas of sparing, later turned out to be COVID. And otherwise, the very most common presentation, if I could say, is it's more of urticaria, urticarial rash, and vasculitic lesions again was very less. So, ma'am, you had some almost 50% in the very severe group. So,
yes, that stands to reason. Vasculopathy is so severe that the disease is severe in them, which is also affecting the skin. And fortunately, in this third wave, we don't come across any of it.
okay.
Because all
So,
my study was done during the second wave.
second delta, okay. So probably like, so that cutaneous manifestation could be made as a, how you can classify the severity also based on the cutaneous manifestation. That must be your inference, no ma'am, from your study.
Yes, madam. Yes. If you have vasculitic pathology, you know that the disease is going to become severe, if not today. You need to be extra careful because without heparin, why should the skin bleed?
That's very interesting. I do. We also did during the second wave towards the end, but our incidence of vasculitis. So we thought probably like it's like a pseudo chilblain. Is it because of the weather, or we had very less, but definitely purpuric lesions were there present in patients with anticoagulants. The other thing which we sort of saw was few herpes zoster post-vaccination. Again, ma'am, have you seen any lichenoid eruption, lichen planus, which occurred after vaccination? Any?
That's what, ma'am. They come and tell it is post-vaccination because now
Correct.
the vaccination drive is so much. Everybody is
Yeah,
what to say?
exactly. So
Everybody is being vaccinated.
So I don't know, some little more, I feel like we have to again do retrospective studies to see whether
Yeah,
it's there
retrospective
any
studies.
increased incidence. One interesting case I would like to share is a patient on leprosy who was quite stable, no reactions at all. After taking vaccination, developed a type 1 reaction almost maybe 3 weeks down the line. Again, vaccination can cause reaction, that is known thing. So that is one interesting phenomenon which we one patient we had like that. So all this could actually definitely would change the dermatological a pattern of our population.
And one more interesting thing, ma'am, we don't do RT-PCR for those asymptomatic patients. But this time we happen to do an RT-PCR because we had to keep those patients for exam. And incidentally, we found 4 of them to be positive. They were all very comfortable. And what we did was we just stopped the steroids, methotrexate, sent them to the COVID wards, kept there for 7 days, brought them back, and started reintroducing our steroid and methotrexate. So this wave is having little mercy on us. So the disease is not worsening, be it the COVID or the dermatological manifestation. Only for very few patients it is really bothersome. Like this drug reaction patients, we were not able to save the patient after the patient acquired COVID infection.
Now you had shown pictures of erythroderma along with the so.
Ma'am, I have seen them actually. I want to share that in detail. When I was making rounds, 3 patients with psoriasis were in the ward in Stanley. They were fit for discharge because there no comorbidity for them. They can be transferred to the Corona Care Center as per the reports related to COVID. But they were scared to send the patient because the first diagnosis was erythroderma for one patient, pustular psoriasis, for another patient, plaque type psoriasis. So they did not know whether to transfer this, whether anything would happen. Then I said, it is all under control. You can definitely transfer them to the Corona Care Center. And it was not actually, it was just the stage of exfoliative dermatitis, and pustular psoriasis also was improving. Even recently, last week back also we had a pustular psoriasis, COVID positive, but they do not flare up. I do not know for what reason. They don't actually flare up following COVID infection. And
these
almost
are
everybody came
patients.
back to our ward.
Okay, these are patients who already was diagnosed with the disease who got COVID.
Non patients.
No.
Patients.
Do you have any patient which you remember after seeing the skin manifestation, you would have thought of oh, this is COVID, or was there any patient with?
No, I thought of COVID, but I did not tell. But fortunately, they also didn't develop COVID because during that period, we used to get so many photos. Every insect bite allergy, every urticaria, every purpura, any small rash, our friends will send a photo of their kids and relatives, fearing whether it is COVID. From all over the world, I used to get pictures. To the extent that even our Campbell de Morgan spot, suddenly they noticed the trick spot. They were scared whether it was due to COVID. So that kind of scare was there amongst people because anything that they see on the skin, they wanted to know whether it is due to COVID. So that way we were not able to say, you're having this, go test for COVID. No, that's what we do not have any pathognomonic skin finding to make a diagnosis of COVID-19 infection.
One more recent study from Delhi by Dr. Kabir Sardana. They also have actually very low incidence of cutaneous manifestation. So we were also wondering, like, but after seeing yours, it's like quite.
No, actually, when you see it is 5,460 patients.
Yeah, it's a big number.
Yeah, number is big. So that's why I was able to collect more pictures.
Very, very well done study, ma'am.
Because that was the time when we were in the peak.
I think this wave we had there was no skin manifestation at all. I think it was very mild disease. No,
Very mild.
and
Because
even
it disappeared in
admissions were
5 days time.
very
Yes.
less.
Very less. Only for coma, patients with coma, they're being admitted for follow-up. Unfortunately, this should end with this.
Thank you, ma'am.
And we were not able to do biopsy for any of our patients. That is another handicap. And this is once in a lifetime we see this COVID and these skin manifestations. We won't get another pandemic like this, hopefully, and we don't want it also. So this histopathological findings are all done. I mean, I have taken from the literature only. We could not do biopsy and prove because, as VC ma'am rightly said, our concentration was life-saving at those that during the second wave, we were more oriented towards saving the life.
Even we didn't know what the protocol was for doing the
Yes,
biopsy,
ma'am.
sending,
Yes,
going.
yes.
Even when we
I
wanted
know.
to do a Zank test, it was so difficult. Our doctors were there, but to how to take the material, people were scared, and we
Yeah,
didn't know
yes.
the infectivity.
We didn't know how to go about it also.
Yeah, we tried, but again, we also couldn't do any of the biopsies the same.
Just a minute. Actually, COVID, even though it has a polymorphic manifestations, but there is no specific manifestations. All the manifestations are possible, from vasculitis to urticaria to PR like rash or vesiculobullous lesions like CP and everything. But there is no specific thing you are COVID patients like that. There is no cutaneous marker for that. So that's the one thing we can assure the patients. And this third wave, like the recent thing, most of them are undiagnosed. They stay at home, even though they had 1 week fever. There is not much skin manifestation they reported for us. After the fever, not much of a thing. And only thing I noticed is COVID, post-COVID hair loss. But that is for any fever, it is possible, telogen effluvium. But what is the report in your setup, Dr. Parimalam? The
It is severe because
severe.
compared to other fever and other illness, this post-COVID hair loss is very severe, and the patient themselves are bringing, like we've been seeing, if it is ordinary fever and telogen effluvium, they're not much bothered. They say within a period of 15 days, my hair has become 1/3, 1/4 like that.
I would like to share one experience. It's one of our postgraduate who got COVID in the second wave. At that point in time, she had a severe, meaning urticaria, which, and it subsided with antihistamine. Again, this way, we didn't test her, but she had URI, ILI-like symptoms, and again, urticaria, which needed with severe involvement, which needed, steroids. Just to tell that, she never had urticaria before, but only twice, and both, say, during this
Due to
probable COVID. So we can sometimes say a presumptive thing when there is a, like
Previous history.
So this patient both times manifested with skin urticaria.
She had similar, because she was with us, we could tell.
It might be some variant of COVID or something, or any other viral flu like thing it might be.
But she never gets it before with other virus.
Yes.
So
If there are any further opinions and comments, I do find Dr. Jayakar Thomas in the hall. Can I invite some comments from Dr. Jayakar Thomas?
Thank you, madam. Thank you, first of all, for your invitation. But for your invitation, I would not have been here, madam. I must say there are a few things that could have been added. I heard that from the speaker that there is no pathognomonic cutaneous manifestation. Unfortunately, I am not able to share my screen. Otherwise, I'll be happy to show something very, very amazing. So there is a study, and it has been reported in the dermatologic therapy, for which I am an associate editor. That's why I became interested in this particular study, where they say chilblain-like lesions could occur in children. And when their nasopharyngeal RT-PCR is done, it shows positive. Otherwise, they have no other signs and symptoms of COVID at all. And that article is so good, madam, you must please follow this one thing, which I would like to say. There is no other signs of causes for chilblains, no Raynaud's phenomenon. There may be some overlap, I suppose, in these patients which were included in these studies. And there's incomplete medical history probably that has been taken. And the investigators conclude that recognition of chilblain-like lesions on the skin as a possible cutaneous presentation in asymptomatic children with COVID-19 is important, along with isolating the affected children to prevent the silent spreading of virus to others, particularly to high-risk individuals. Now, this I thought is something which is really what we should record and document, particularly in a setup like what Dr. Dinsey has got in pediatric dermatology. When these children, asymptomatic children, come with chilblains, make sure that we rule out. And at least the minimum thing is do an RT-PCR and make sure that, because you have to isolate these children. That's a huge big study. That's also not even 5,000, it's more than 15,000 children they have studied in the dermatologic therapy article. I can share it with you all in your email IDs because I'm not able to share my screen right now. So I thought since Madam VC had asked for something new in this, I'll add on this. Chilblain-like lesions in asymptomatic children could be a possible danger to the others in the family. Thank you, madam.
Thank you, sir. Thank you. That's a new bit of information, and I suppose Dr. Parimalam and Dr. Dinsey and the rest of them take note of this, and probably this could, help our dermatologists to take some clue on and proceed further. And inviting opinions from anyone else in the hall. Anyone else? So I suppose if there are no further comments and opinions, we'll thank Dr. Parimalam and the two panelists. Yes, true, COVID had a kind of wrecked the entire world. And as Dr. Dhanalakshmi said, there is no particular thing that can be attached to COVID, and there is no particular thing that cannot be attached to COVID too. Anything can be COVID and anything cannot be and need not be COVID. And probably, ma'am, as you rightly said, with regard to the hair loss that COVID patients suffered post-COVID, could also be more associated to their psychological status. Right in the first wave, if you remember, people did not even want to have an RT-PCR done, primarily because they were scared that there would be a stigma attached and if they are found positive. I suppose all those factors have contributed, more of psychology which has contributed, the thinking process. I know of people who were admitted for COVID, but then every evening they would see some kind of nightmarish dream, some kind of, an imbalance which even a normal educated individual suffered. So all these probably would have contributed, and I would only request experts like you, specialists like you, to go into the details, and as Dr. Jayakar Thomas said, maybe a little more research into this area if possible. And I also agree with Dr. Parimalam when she said it may not be possible to do certain research work primarily because we were more worried about the life of the individual than anything else. But if possible, more light can be thrown into these areas, at least for posterity. Touch wood, we would not want another epidemic, but if something can be learned and this learning can help in future times. Probably experts like you can think of it. With that, the university is happy to thank Dr. Parimalam Kumar and Dr. Dhanalakshmi and Dr. Dincy Thomas for a very wonderful afternoon, and Dr. Jayakar Thomas for joining us and giving that touch of a special stroke. Thank you very much, and let's meet once again on the 18th of February, the third Friday, for yet another edition of the University Webinar Series. Thank you very much.
Thank you, madam.
Thank you, madam. Thank you so much, madam.
Thank you.